Now I'd like to introduce our speaker for today. This is Dr. Paula Cupertino. She's an associate professor of preventive medicine and public health, as well as the director of Juntos, the Center for Advancing Latino Health at KU Medical Center. As a social behavioral scientist, her research is focused on smoking cessation and access to cessation, treatments among underserved and underrepresented populations with a primary focus of Latinos. And today she will be speaking about SMS, text intervention methods applied in the United States and Mexico as well as Brazil. So without further ado.
Great, thank you. Thank you for the introduction. I had this morning at least 10 reasons why I shouldn't come here today. Some of them more obvious than others, but why not? And why not take the time to just stop a little bit, everything, the craziness going on, to just talk about something that I'm very passionate about. That's that sometimes as you move along in your career, you just disconnect, you know. So hopefully by the end of today, you will get that here there is a person that's very passionate about immigrant health. I wasn't born like this. I was born in Brazil, and something that motivated me growing up was social justice movements. And if you know a little bit of Brazil, you can kind of understand why. So that was growing up. That's something that always, you know, bothered me, something that I was interested in. And as I moved along, I ended up doing a career in public health. Brazil didn't have that many opportunities for doctor programs. This is how I ended up at the University of California, Davis. In my first week at Davis, growing up, I lived in Argentina for many years, so I was fluent in Spanish. And my first week at the medical center in Davis for my doctor program, coming from Brazil, never thought I was going to have an announcement to work in the Sacramento area Latino study on aging. And that's how my first week in the United States, about 20-something years ago, I immersed myself into this enterprise at the University of California, Davis, in which there are many research projects happening in the immigrant Mexican community. So this is what I was raised, and when later on I had the opportunity, due to family and actually due to September 11th, I ended up in Kansas, and California said, there are no Latinos in Kansas, what are you gonna do there? Your career is over, there are no immigrants there. And as you know, I have been, after 10 years at the medical center, I'm very happy that not only I found the Latinos in Kansas, but they have given me the honor to develop my academic career, trying to understand why Latinos smoke at a different patterns than Anglos and African American, and how to treat them. And more than anything, I have had the honor to be able to expand the knowledge that we develop here, where we have more funding for clinical trial studies. I have been able to do a cross-cultural studies that at the same time that we're developing protocols here, we are working with Mexico and Brazil in pilot testing and moving the protocols into trials. So I'm pretty much, this is it. This is all what I have to say to you, that this is what we do at Juntos, Center for Advancing Latino Health. Check our website, we do many other things, but today I'm gonna focus on the SMS and the smoking cessation because it has this Latin American cross-cultural that I think is more relevant to you. At Juntos, we are very particularly concerned about the lack of representation of Latinos into the medical and health careers. So we have pipeline projects. We have an NIH grant to work with high school students, undergraduate students, master level. We're very concerned about moving. How many Latino faculty do you think it's at the medical center now?
Judging from what you said, quite a few.
How many faculty? Probably 2 or 3, right? There are very few of us still. Very few Latino faculty researchers, and let alone working on Latino immigrant health. You might have a Latino researcher, but it's working on something. So there are very few of us, and I take that very seriously, especially because I want to retire, right? So we need to grow our pipeline. And the other thing that we do at Juntos It's a community-based participatory research program. We can't be developing or thinking about research if it's not grounded with the community. So you're going to see juntos all over the state doing health fairs, participating in community events, mobilizing community. We have one full-time person working out Southwest Kansas that mobilized the Latino community out there. At the same time, we have about 12 people on the staff right now in Kansas City, mobilizing organizations, participating on the issues that are relevant to Latinos. And within that infrastructure of community-based participatory research, we put our protocols. So I just want to make sure that and if you go through our website, you can see both our commitment to pipeline and our commitment to make sure that this is embedded in the community. And I think this is one of the reasons why we have been so successful. I don't need to spend a lot of time there, but we know that cigarette smoking is the chief single avoidable cause of death in our society and the most important public health issue of our time. We need to do something. Right? I work within the medical center. You probably have heard about the Kansas Cancer Center. It's a big enterprise, and we are NCI designated. This morning, we are trying to move into a comprehensive cancer center, NCI designated cancer center. So we have been together with today, the NCI is here reviewing our center to see if they will fund us to be a comprehensive. So it's a big deal, and tobacco is out there. So we don't need to spend a lot of time, but we know the industry is pushing, and we are not only dealing with a disease. Smoking is a dependence, right? It's a chronic disease that involves addiction, and we know that we are battling a big industry that's very powerful. And we know quitting, we are not quite there yet, especially when we start looking to underserved community, to special populations, developing countries, where we particularly see in Latin America the growth of smoking among women, right? But the good news, after sharing some bad news, there has been years and years, decades of trials. We know how to treat tobacco dependence. Does anybody know how if someone is smoking, and what is the treatment? Smoking cessation treatment. So we know that individuals that are using, I'm trying to do this here. So there are two components with the smoking cessation treatment. If you use them, I don't care if you're ready to quit or not, if you're thinking about quitting, when a diabetic comes to your clinic, you're never going to ask, would you like to treat your diabetes, right? We're never going to ask. Would you like to treat your hypertension? We just treat. So this is a model that we use, and we know that the individuals that use medication combined with a counseling, different modalities of counseling, they are 25% more likely to quit smoking. Okay, so lots of our protocols is just to make sure that we connect individuals independent. I'm not going to be sitting down and waiting for Latinos to knock the door of the medical center and ask, I want to treat my tobacco. We're out there making sure, and we're never asking. It's very different if I ask you, would you like to quit smoking, than if I look at you and said, there has been people who use different methodologies to quit smoking. They have been very successful, and the number of ex-smokers has been growing every year. Would you like to try some of this? It's completely, I never ask if you want to quit, yes or no, but I'm just engaging you, because what we know, most of smokers want to quit, and they probably every Monday they try to quit, right? Like some of us try to do other things. Monday I'm going to change, right? But without using the evidence, treatment is not possible. So we're trying to expand and think about this paradigm. The medical center is well known about treating and understanding the process of getting African Americans to quit. And I was hired about 10 years ago to work with the Latino community, to replicate what they have done in terms of breakthrough science, to understand how African Americans, and I have been leading the Latino work. So, and then we start thinking about lots of cross-cultural issues. You know, what is the participation of Latinos on these trials? Like many, many millions, decades of studies, what do you think is the Latino participation on these trials that has shown us that this is the results, how effective they are with the population? Like, if there is a trial on smoking cessation happening, what are the odds that Latinos are getting recruited? What are the odds that the protocols are translated to Spanish? They're culturally appropriate. What are the odds that the population, they're going to have individuals bilingual to enroll, to engage? What are the odds that this Latino is going to say, okay, I trust you, I'm going to work with you, right? What are the odds? So as you can imagine the answer, out of the decades of studies, the last study conducted with Latino focus was 20 years ago. They're a very handful. And you have a couple of studies that have enrolled 5% of Latinos. So we know very little about Latino smoking, but we do know that they are light smokers, right? While the Anglos tend to smoke 20 cigarettes a day, you can find Latinos that smoke every day 3, 4, 5 cigarettes. Some of them don't even consider themselves smokers, or they are non-daily smokers. You know, I only smoke on the weekends, I smoke only when I'm at this place, right? But we know that there is an addiction. If not, they wouldn't be smoking. We just don't know how to treat, okay? So we know that Latinos smoke at a different rate. And then it's fascinating to me because you know my bias is try to see how that happens with the Mexicans that stay in Mexico, or the Latinos or the Brazilians, or is it true that they are all light smokers, or only the Latinos that are in the U.S. that are light smokers? So you start getting into this kind of questions, and that fascinates me because then there is an opportunity for true collaboration between two countries, right? Okay, tell me about how your surveillance, how are your smokers, and how do you treating them? Let me tell you how we treat ours. You know, and then it gets fascinating. I strongly recommend, I don't know why you're here today, but you're probably interested in doing some cross-cultural work. It's just fascinating when you truly open yourself to stop looking at what is right and wrong, but really how these different protocols, different ways to approach one specific topic here, smoking cessation, can just be enriched over time. And over the years, the reason I'm here, I'm already looking, it's 12:20, and you can see how I'm passionate about what I do, can come across very easily. And I'm here today to talk that over this 10 years working with smoking, we have identified that SMS, we have tried to engage smokers. Our protocols, United States have a quit line, right? Smoking cessation quit line. You call 1-800 and there is a counselor and set sessions with you. That doesn't seem that's something that works with Latinos, right? And we have tried phone-based protocols, and the engagement has not been that great. We have tried in person, and in person is too expensive. How are you going to get counselors? And we know that especially in the U.S., Latinos are more likely to be under the poverty limit. They're less likely to have access to health care. So it's just, so here it is. We know that 80% of adults text. We know that they read their text message within 3 minutes, and they keep their telephone, even when they go to sleep, very close to their reach. Right? So we begin to look, and this seems that even more prominent among underserved communities. Latinos, all the Pew studies show that their utilization of text messaging is much higher than any other group. It's their way of communicating, and there is also issues of cost, right? Unlimited text message. So it's an amazing opportunity to disseminate evidence-based treatment. But how are we going to disseminate through text message? That's where comes my research. You know, the population reach. We developed something similar in Brazil for a business and for their Telefônica, the biggest enterprise in Brazil. And within a couple weeks, we had like 20,000 people utilizing the smoking cessation intervention. So the population reach, and it's very cheap, right? You pay in Brazil, I think was like $2 a month to get access to a smoking cessation program, and it's very, and you have the opportunity to personalize care. You know, nowadays with this technology, you have so many opportunities, and it's definitely a new modality to address health disparities. Individuals that cannot get to the doctors, you just bring the health care and the care management to their hands. And then it's low cost, and it's just timely matter. If I don't want to read my text message from my counselor now, I can do it later. If I'm at work, right? You organize around your own schedule, and it's right here, and at any time you can just request for more help if needed. So we had the opportunity at some point. You know, there are lots of marriages that don't go very well, but this is one marriage that has happened throughout my career that has been just outstanding. We have met Agile Health. Agile Health, it's a company that delivers health solutions via telephone. So we met Agile Health, and they had a problem. They had purchased Kick Butts. That's the program that was developed in New Zealand, went through a trial, a smoking cessation program, SMS, text message, developed in New Zealand. A trial showed that people using that more likely to quit. That trial was replicated in England. And again, people using SMS to quit smoking were more likely to quit than control. So Agile Health purchased that library and adapt to American English. So, and now they're selling, they're a business of healthcare solution. They sell, one of their clients is Walmart. So it's available massively throughout the country through the wellness programs, right? KU has their wellness. They want people to be healthy, especially when there is a cheap solution, such as, and with a high impact, like helping people to quit smoking. So Agile Health approached us that there is the growing of Latinos, and the utilization of their text message software among Latinos has been close to zero. So there is this huge market of Latinos. They know Latinos are the faster adopters of these mobile tools, but the utilization of smoking cessation. So they approach us, maybe Latinos don't want to quit via text message. Maybe our program is not culturally linguistic appropriate. So they had a problem, and we applied for a business grant out of the National Institute of Health, NIH, and we were successful. And here's the trials that they did in England and Australia. So we know tobacco is very important to address with Latinos, and there is variability by national origin. We know that here most of Latinos are from Mexico. In our studies we tend to see, and we know that Brazil is very similar to what we see in the Mexican community. So we knew that we were tapping into something with a lot of potential, right? So we began to think about what would be a culturally sensitive intervention, an innovative strategy that is needed to help Latinos. Text message is a way to do it. It's affordable. They don't need to go to the doctors. How can we adapt all this knowledge, scientific knowledge, to the community? So this is where we had Patelo. This was like 5 years ago, our first work, even to look at, does this work? Does even Latino care about quitting? Remember, I have done trials with protocols of phone calls, and it didn't work. You know, it didn't work because it's just, they have 2-3 jobs, and it was so hard to keep them engaged in the trial. It just didn't work. And we have published that work. We were very disappointed. So we did an adaptation. We work with, remember, we don't do this without the community. So we have a community advisory board. We have promotoras de salud. We have within our team, if you're ever in Kansas City, you want to visit us, Juntos Center for Advanced Latino Health. We have lots of internship opportunity, always. And you're going to see we have a team with people that look like the community and are immigrants and native Spanish speaking. I think I'm the only one who is not native, originally Portuguese. Spanish is my second language. So we did focus group, and we did a lot of work with the library. Even though the library was translated to Spanish, the translation was just not culturally and linguistic appropriate. So we spent quite a bit of time and then in getting the whole process going, and then we developed our crazy protocols to monitor, to call, and it's just the clinical protocols that goes behind to evaluate, to truly be able to say, does Latino quit with text message? Because if the answer is no, we just drop this, right? And then there is just an unbelievable amount of work behind, because we can see daily what is the interaction that's happening, how many messages are going out, what kind of messages, how many people are in the 5th day, the 7th day, and it's just there is a whole operation, and I have people almost literally 24 hours a day, not really, but almost like 8-10 hours a day, because you become addicted to just see what's going on with your population when you have the opportunity. And everybody in my team, I think I'm the low, in levels of caring for this work, I think I'm the lowest one. I have people that truly, truly care about this. Why do Latinos smoke at different rate, a different pattern, and how do we help them quit? We are very, very committed. So the first thing that we saw, Agile Health, they have years working with the software. The software, the text message, the software that sends the text message has 3 levels. One level, you just get 3 messages daily. The other one, if you have an emergency and you can type a keyword, right? And ask for help, for craving, I'm facing stress, you have a keyword. And the other option, that's the hardest one to have in a software, is the interactivity. The person can type any word, any character, and we are gonna recognize. So this is what Agile Health can just have, this 3rd level. First week in the trial, Agile Health, their experience that in their population work, how many messages do we think the interactivity one, a participant on Agile Health, Anglo, African American, send to the program? How many messages a day? I'm trying to quit and I got a message. You know, quitting is the most important thing you do. You should talk to your doctor about using cessation medication. Cessation medication can double your odds of quitting smoking. Have you talked to your doctor? You're getting messages like that. That's giving you the logistic and the support. Talk to a friend that have quit. Maybe he has tips to help you, you know? And so you're getting these messages. How many messages do you think people are sending? How many messages would you send to the program? 2? Yeah, like, okay, thank you. This is cool. Yeah, I don't have a doctor, maybe, right? Okay, so as soon as we got to the trial, we were blown away with this. You know, the number, 478 messages, 17 participants. In average, Latinos are exchanging about 36 messages. And it's not only, okay, thank you, I don't have a doctor. It's like, I'm so sorry that I didn't answer you earlier. But I was in the hospital with my daughter because she felt, and then my husband didn't have a car, and then they're truly engaged. There is a component. Thank you so much for helping me. I have never had someone that paid attention to my quitting process and blah, blah, you know? High levels of it. Messages, long, 1, 2, 3, 4 messages. And then you can only imagine what happened to us. We were fascinated about that phenomenon. Agile Health has never seen this with any other population. So it looks like we're touching something. And for us who are Latinos, we kind of like, I get it. That's kind of my message is how it goes. You're just like, you know? Someone say, hi, how are you? And you're like, rawr, you just go on and on and on, and you share everything that happens to you, right? Okay, so we were just blown away with these initial results. You know, people, free text message, people who out of the blue that just like, start sending messages. And keywords, utilization of keywords used to be for Agile Health close to 3%. And suddenly we get like 25%. They are using. So remember that initial question, do Latinos care about quitting? with text messaging. It looks like at least we're keeping, because a big component for you to quit or make a behavioral change is the level of engagement. If you don't want to do it, if you're not engaged, you're not going to change your behavior. So it looks like we're touching to something. Here's an example. Right? Tengo 38 años, 3 niños pequeños, quiero dejar de fumar para disfrutar a mis hijos y conocer algún día a mis nietos. So there is a message about quitting is the best thing that you can do for your family. This is what we get for the answer, right? So the person is really, even though they know it's a machine that's sending the message, they know that there is that, someone is reading. And actually, we read all of them. So, and it blew our mind that we got a cessation rate that's out of the chart. 25% to 30% cessation rate. And then we have about 38 SMS messages per participant. 100%, the best, remember, if you use medication, you're twice more likely to quit smoking. We had, by interacting, when we call them 3 months later, 100% choose their NRT, compared to like 20% in Agile Health database. So they're using evidence-based treatment to quit smoking. And 66% request a refill. They not only request the first time, but when their refill was due, they submit the request for the refill. This blew our mind. Keyword use was very high, from 4.8 to 13%. So we're like, yes, it looks like we're touching into something. And then, but the cool thing that I do is that at the same time that we're doing this, we are, now I won't be able to find, yes?
Oh, it's,
is that overcome?
Yeah, it's yeah.
Okay. So at the same time that we are doing this work here, we are doing this work in Mexico, right? So we're learning about these things. Mexico usually goes a little bit behind because funding is much harder to get research funding. But we can't complain. We have been very fortunate, both in getting funding from Mexico and from the NIH, from the US, to fund our research there, because I think that we are doing something that's it's making sense and we are showing the outcomes. So, but when you move to Mexico, you need to be open that you're talking about, how can I say? You just need to really be open that you're gonna find, you need to adapt, you need to tailor, you need to be open to understand what are the characteristics of the population. And as soon as we got there, guess what? The population in Mexico we can spend hours talking about the healthcare system, but there is a Seguro Popular. The government takes the health. They're close to be a universal healthcare system in which the government it's responsible for the health of their citizens. So that changed completely the paradigm, because right now we are getting through the text messaging, enrolling participants through the grassroots, because they are not in the hospital, they're not at the medical center. There we have our smokers, we have a captive audience within the healthcare system. So what we did in Mexico, so here we do a different way to get to the community. In Mexico, what we did, we developed a kiosk that was placed in the clinics. And it's pretty much this what it does.
Hola, te damos la más cordial bienvenida al programa de ayuda para dejar de fumar. ¿Vives sin tabaco? ¡Decídete!
¿Has intentado dejar de fumar con anterioridad? Liberarse del cigarro es la mejor decisión que puedes tomar para mejorar tu salud y calidad de vida.
Dejar el tabaco no es una tarea fácil. Es por eso que te queremos apoyar brindándote información novedosa sobre los tratamientos que harán que este intento sea más sencillo y exitoso. Siempre contarás con un equipo de profesionales que te acompañarán durante el proceso para dejar de fumar. Este programa es gratuito y tu participación completamente voluntaria. También queremos hablarte sobre los medicamentos que existen actualmente para que puedas iniciar una nueva vida, libre del cigarro y del humo del tabaco. ¿Te interesa? ¿Quieres saber cómo funciona? Entonces acompáñanos en este recorrido.
Conocer sobre este programa solo te tomará 15 minutos de tu tiempo. Queremos que nos ayudes respondiendo algunas preguntas muy sencillas. En la mayoría de ellas solamente tendrás que señalar una respuesta. Solo te pediremos algunos datos de identificación con la finalidad de darle seguimiento a tu solicitud. Si tienes dudas, puedes solicitar información al correo electrónico vivesintabaco@controltabaco.mx o al teléfono 55 54 87 1000 extensión 3276.
Al terminar de contestar las preguntas, recibirás una hoja personalizada con información sobre las alternativas de solución y tratamientos para dejar de fumar de acuerdo a tus necesidades. Recuerda, siempre contarás con el apoyo de nuestro equipo de profesionales que te acompañarán durante el proceso para dejar de fumar. ¿Te gustaría participar en nuestro programa? No te arrepentirás de haber tomado esta decisión. Buena suerte y adelante.
Does that make sense? So, I don't know how many of you speak Spanish, but it's always fun, right? To listen a different language going on. Let me just get this. Right? Okay. So when we went to Mexico, as soon as we got there, we realized that the healthcare system is different, you know, and then you have many discussions with your investigators because no, if you change this, you're changing the protocol, and then the results are not going to be valid. So you have two approaches when you're taking a cross-cultural validation. Or you go with your model from the whatever it was developed, in this case in the United States, and you just get that model there, or you just go through the process to understand from experts, from leaders in the community, from smokers, and how do we get to, you know, to adapt. And there is tons of amazing publications about cultural adaptation of health behavior change interventions. So there is a number of researchers from Oregon that has done this work and has told us, we have spent a lot of time just getting one model, usually from the United States, where they are developed, translating and putting in other countries. That's not going to work, right? So what we did here in the United States, I told you we have community health workers, promotoras de salud that look like the community, talk like the community, get into the community to enroll participants. In Mexico, we have this tablet with un galán, like telenovela, right? Someone like to invite the people to participate. And this was placed in the clinics, in 2 clinics in Mexico at this point. And through that, as you complete that, you start receiving the text messages, right? So it's a completely different way, but the content of the intervention is the same. So we have learned tons by doing, and then you can spend quite a bit of time. Are we tailoring? Are we adapting? What are we doing? But most importantly, and you interested in Latin American studies, we need to make sure that we're building infrastructure in Mexico. We could be doing all this work and relying on infrastructure from the US, like Gateway, the technological infrastructure. I could have research from the US, but that's not the point. You know, a true collaboration, it should be work to the development of both countries. So this has been something very close to our heart, to make sure that we develop text message research capacity in Mexico. So our gateway, right, I can't explain that, but the technology that allows you to deliver messages to carriers in Mexico, I could be hiring that in the US. But we have been, and that would be, it took 6 months for us to go through that hurdle of figuring out how, which company was able to do it. Not only because of the third level, the interactivity, it's very hard to have, for you to be able to recognize any words coming in. This is why some programs like Text 323, because you only recognize numbers, keywords. So when you start talking about the fluency of you writing and using text message, so that's the level where it gets much harder. So we're building capacity. We work with a team in Mexico, and let me tell you, it's hard. It's hard to work with a team just in the US. Imagine when you put another team. The logistics of the meetings are extremely hard. The way the administration of funding in the US is so different from Mexico. So we spend 3 times more doing this work than we would. But truly, at the end, we truly hope Mexico is developing the skills to work with NIH, to follow the requirements. And this will open opportunities for future studies for other researchers, right? So we work with the Instituto Nacional de Salud Pública in Cuernavaca. I have the opportunity to go there 3, 4, 5 times a year. It's a wonderful place, and really they are is an accredited public health institution, accredited by the U.S. patterns, and it just has been great. But we have this strong commitment, and then to show our strong commitment, every year Mexico, in all the careers, when you finish your career, you need to give 1 year to the government. It's called Servicio Social, right? So because of our work, we did an agreement with Mexico. We take kids, medical students, nurses, and nutritionists, that for their Servicio Social in the US with us. And we do the same thing. Right now I have 5 medical students there. And we do this exchange because we truly believe we need to enhance the young cohort's understanding of what it is about truly working bilateral, not only one country benefiting, all of that. I don't need to go over. So there is a major difference in healthcare system. In Mexico, IVR, it's a technology that's more used. They do not have quick lines. No wonder it didn't work here when we tried to talk to people by phone. And the same in Brazil. And WhatsApp is the way they'll communicate. It's much cheaper, is the way to exchange text message. However, WhatsApp is still not allowing us to deploy the study through the SMS and use the text message interaction through WhatsApp. But apparently Facebook just bought WhatsApp, and then there are things coming up along those lines. NRT availability, varenicline use. NRT is a very affordable medication. There has been many studies showing that varenicline, very expensive medication, and NRT have the same cessation outcomes. So, should Mexico be investing in having NRT or varenicline? NRT is over the counter. Anybody can buy. This one you need to see a provider. Which one should Mexico be investing? NRT. Which one should the US be investing? NRT, of course. In Medicaid and Medicare, you can get NRT for free. Most of the programs, they allow you to use. But guess what? In Mexico right now, there is a shortage of NRT. It's out of the market. Varenicline has taken, pharmaceutical, have you heard that they're quite powerful? Has taken on the market. So we have this protocol happening in NRT, it's out of the market. So we have been literally going pharmacy for how many boxes do you have, how many boxes? And it's fascinating because one of the reasons when you talk to the providers and the big leaders there, it's because Mexicans do not use NRT. They do not use patches, and I'm like, it's interesting because I work, but Mexicans in the US is different than Mexicans in the Mex. Yeah, you're right, and it is true. What I'm going to see, I am so curious. This is a study we're going to launch in March. And now that we have the NRT against all the governments, all the pharmaceutical, nobody wants us to do this with NRT. We fought for that because we're looking forward to have results and show, guess what? They do use NRT. And it's no contraindication, over the counter. It doesn't make sense, right, to be pushing. But guess what? Most of the providers that we work and they are in leadership, they, and I have no problem to say the same thing in Brazil, they get paid by varenicline. to be all over the world giving talks on Merienda Clean. So it's all this, I just met someone that's doing a dissertation about the market and how the impact on health. And so technical gateway, and it's been fascinating. We had the opportunity to translate what we have done in the US, our messages, our library, and bring to Mexico, right? Would that make sense? You know, in my team, I have five people from Mexico, born in Mexico. So we could get that library, Patelo, Latino Kick Butts, and get them to develop. But I said, no, we're not going to do this. One, because I want a library to be the ownership of Mexico, right? And if it's to be the ownership of Mexico, Agile Health owns the rights on that content. I want Mexico, the government, the institutions to have it. So we start from scratch. And we knew, man, it's going to look the same. We're going through it's a lot of work to develop those text messages. We develop for each trial, it's about 900 text messages. And they need to be very short. They need to cover at least 5 theoretical principles. It's just a lot of work. But I have a team that's committed to do it. So we develop, guess what? The content is so different. The library in Mexico, just the style of communication is very different than developing with the Mexican. Remember, we do focus group, we have promotoras de salud, but they have been here for 10, 15 years, 8 years, right? So the content for the Library of Mexico talks a lot about air quality. Here, no one has ever told us that air quality was a concern as a smoker. Clean environment. Right? There are lots of messages about not throwing things. If you stop quitting, the environment's going to be more clean and very interesting. And those, remember, those is the community and with experts developing. Gender differences. You know, the community in Mexico were very persistent on like, no, it needs to be femenino and masculino. You need, the community here, it's fine to have a more neutral, you know, they see that, they want tú or ella, they see that they want to be very gender specific. And that has not been an issue here. Just the language, the style, right? And the tobacco industry. That's a big issue for Mexicans here. Our library has never talked about how if you smoke, you're making the tobacco industry, you're giving profit to someone. That's not, and cost. It's a concern in the US. Cigarettes are expensive. Over there you can buy singles and it's very affordable. And you have a lot of smugglers coming in. So cost is not an issue there. So that's quite interesting. But we also have the similarities. You know, Mexicans in the US, Mexicans in Mexico, they are light smokers. It's about 80%. In our, among Anglos, you have about 8% are light smokers. Here you're talking about 80% light smokers, right? 60 to 80%. And decide sin fumar. So we face a very similar issue to what we have here. Most of smokers don't want to quit, but they haven't quit. And they haven't used what is evidence-based. So no matter if they are in the US or in Mexico, we still find the same. So this is and we have the same protocol. This is going to start in March. And then we do the same work in Brazil. And then Brazil is at the same level as Mexico. We are launching the study. Actually today, we have a large study, a clinical trial study being evaluated. Keep your fingers crossed that we're going to do all this work that's already funded in the US, in Mexico, we're going to take to Brazil. So it's getting evaluated today. In Brazil, it's a different scenario. You know, you have in the Brazilian government, we are the second largest producer of tobacco. In the south of Brazil is where you have the high prevalence of smoking, and it's growing very fast among women than any other Latin American country. So, and guess what? Light smokers again. What it is about Latinos being light smokers, we don't know. In part because all the trials that have been done have excluded Latino, light smokers, right? that have excluded them. So we don't know. So this is Brazil is the second largest producer behind China, right? And and there is a lot of going on. Even the addiction, just by collecting, being in the fields, you just develop dependence to nicotine. And so there are lots of kids at very young age on the south of Brazil that is starting addiction, and there is some study. So we have with Brazil, we have done, our partnership is with the university in my hometown. It's about 2 hours from Rio de Janeiro, Juiz de Fora, and we have been able to move the research forward at a much faster rate than Mexico. I would say that in Mexico we have been able to really integrate within the healthcare system faster than in Brazil, but the research component in Brazil, and we have several publications with Mexico, we have very few publications at this point. And this is, again, we went through the same process, and as you see, completely different than the fuel intake of what happens to Mexico. But we went through the same process to do the cultural adaptation and the linguistic. And very similar again to what we describe in Mexico, right? In Brazil, there is another component happening. There is that is not happening in Mexico. I don't know why. They're treating smokers with second-line medication before going to first-line medication, right? Medication in Brazil, it's both NRT and bupropion. That's another medication to treat smoking, and they are available within the healthcare system. But providers lack the training. So often we go to clinics and you have tons of medication expire that haven't been used because providers don't know how to do it. So we're doing a lot of work to increase the training of healthcare providers in Brazil. But the issues of cost are very similar to Mexico, and the differences also are very similar to Mexico. The healthcare system are very different. Brazil has a family medicine model, primary care model, and within the whole primary care model, you are supposed to be addressing the prevention, cessation, and then if you can't handle at the primary level, you send to secondary level. So it has a system, looks very beautiful in paper. In reality, it's very different, but it's working. In IVR, the interactive voice receiver, it's much more likely. So in the cigarettes, if you call the 1-800 number in the US, you talk to a counselor, the quit line. In Brazil, in Mexico, if you call, you're going to talk to interactive voice receiver. Hi, you want to quit? Press 1 if you want to do this. Do you want to know? Right? So this is very popular in IVR. No quit line, and WhatsApp is the interactive mode of preference. NRT availability, again, it's in the healthcare system, but has been underutilized. They say that Brazilians don't like NRT, and they say that Brazilians are prefer varenicline, and in Brazil there is the use of second-line medication that we haven't been able to figure out why. And technical infrastructure, the same hurdles that we had in Mexico, we're having with Brazil, to work with a gateway, Brazilian gateway, for the Brazilian gateway to develop the capability to deliver a longitudinal, because right now Brazil, they can deliver a blast propaganda marketing for this water, and they send millions of messages about this water, but they can't follow up. And our treatment is 6 months long. So just that capability and have that spreadsheet that let us know, that's what's missing, and make sure the individuals are getting the message and they're responding. So that is what I mean by gateway. Sorry if I didn't. And there are 3 components that are very prominent in the libraries in Brazil, is the weight control, exercise, and the relationship aspect of smoking. So this is a part of the team that's out there in Kansas City, and I should have brought the pictures of the team in Mexico and Brazil. But again, as I said, this is the smoking. At Juntos Center for Advancing Latino Health, we have a similar effort around diabetes and adolescents, reproductive health, teenager pregnancy, and prenatal vitamin, pregnant women, utilization of some clinical trials happening. But at the same time, we try to move things with Latinos here, Mexico, and the US. So this is pretty much what I had to share with you. And I still have a little bit of time to talk. Gracias, thanks, e muito obrigada.
A question. Is the system, so is it volunteer-based, or, I mean, can they opt out at any time to stop receiving text messages?
Okay, so we follow all the guidelines that there is, right now we're following, in the US, we follow the civil rights of California, where there is all the specifications. So I think after every certain number of messages, we give the option to click stop and you're out. Yeah. And we had, I think, I don't know if I show, our withdrawal rate is very low at this point. You know, we see that people disengage, and then when we call them 3 months later, they disengage, maybe because they didn't quit or they didn't like the program, right? And it's about 16% of people that just checked out. Yeah, so it's like, consider what is expected in trials, right? To have like 80, what we want to do is get 80% retention rate.
I was really interested in the slide you had way back of the different national origins
Mhm.
and their different percentage of smokers. It was way, way early on. But, so you said Mexicans are light smokers and Brazilians are light smokers.
Puerto Ricans, no.
Heavier smokers?
Heavier smokers.
So there are differences among those national origins.
Yeah, oh yeah, Dominican.
And when you addressed the Latino population in the U.S., was that primarily a Mexican population?
Yeah, remember
or
that I said,
exclusively?
yeah, because I'm
Okay.
working in Kansas, and then in our studies, it's like 86%, 92% Mexican descent.
So we don't really know
No.
whether the same
What is happening?
protocol would work with, say, Puerto Ricans.
No. And I'm happy to share with you, we just got funded. Remember that I said last trial has happened like 20 years ago, focus on Latino only. Yeah, we just got funded like last week. And we have, it's about 3.5 million, and we're going to be looking in the next 5 years, we're going to enroll 700 Latino smokers, and we're really going to get to lots of
bring apart
answers.
the
Oh yes,
disaggregate
lots,
the data,
lots
yeah.
of things, yeah.
That's interesting.
Yes.
Hi, very interesting. Could you tell me a little bit more about where in Southwest Kansas you're working, and if you include social scientists in your team?
Very good question. So in Southwest Kansas, we have, remember I said we have a full-time person that works he lives in Liberal. And then with that, our enterprise we spend a lot of time in Dodge, Garden, Liberal, Ulysses, and that's about it. Yeah. And if I have a social scientist, yeah, we have a social worker, an anthropologist working in our team.
Locally in
In-
Southwest Kansas?
Is
or
in
at the
Kansas
Med
City
Center?
at the Med Center, but kind of is part of the team.
And the promotoras are...
I have promotoras in Mexico, in Kansas City, and promotoras in Southwest Kansas. They're paid, they are part of the team.
So they're paid from your grant, it's not like a local organization?
No, but remember that I said that we have a strong commitment to what is important for the community. So we are part of the enterprise between Mark is leading an effort to make Promotoras de Salud Community Health Worker a career in the state of Kansas. It's not an occupation. So right now, Kansas City, Kansas, Community College, Johnson College, Penn Valley are implementing a certificate. So we're doing that training piece at the same time that we need the government to just create an occupation. So we're doing the business. It's a lot of work. Everything's so much work. Yeah.
It's impressive.
Did you say study cover just cigarette smoking, or is it all types of tobacco use?
Cigarette smoking. They can smoke other things, but we don't treat other. Yeah, and that has become a huge issue in Brazil. Mexico is very low the use of other forms of cigarette, and of course in the U.S. You know, and e-cigarettes is everywhere, right? It's a concern. No, we don't bring only e-cigarettes. No idea what to do with that. Okay?
I see you have it broken into men and women. Do you break it down further into like socioeconomic groups and other types of considerations?
Yes. And it's very interesting because in some groups, the higher the SES, more smoking. And that vary by gender. Yeah. Yes. We have that. Okay? Thank you so much.